So good morning, everyone, and welcome to the Children's Environmental Health webinar series. We're excited to have you here today. I'm Cynthia Lamberth. I'm the Executive Director of the Kentucky Population Health Institute. And we have a really exciting program for you today about asthma and the impacts of that on children. So I have a welcome video that I'm going to show in just a minute, but before that, just real quick housekeeping. I posted in the chat, if you can open up the chat, to get your continuing education credits, or if you want a certificate of completion for today's program, you need to do two things for me. First of all, you need to go to the participant tab and you need to put in your name if that's not what is showing. It's a pretty simple thing to do. Open the participants, and if you hover your mouse over your name, and I know for some of you, it could be a child's name because they've been using Zoom for school, or it may be your telephone number if you're calling in from your cell phone, but I need you to put your real full name. Otherwise, we're having trouble figuring out who actually attended and who didn't for the continuing education. So do that. If you're having trouble, you can text us and let us know that you're having trouble with that, or you've gotten emails from me over the last couple of days, or you wouldn't be logged in. You can also send me an email and just say, Cynthia, I was there, I couldn't fix my name. Some way that I know. So, and then there's a couple more Zoom things that Kara's going to share, but before that, I want to share this message prepared by the Department for Public Health, who is sponsoring this program today.
Hello, and welcome to the Kentucky Children's Environmental Health webinar series. The purpose of this series is to help participants increase their knowledge of environmental exposures and how to reduce these for children. We would also like to introduce you to our Environmental Public Health Tracking Data Portal, which you can access by going to envirohealthlink.org. This easy-to-use website can be used to find Kentucky-specific health and environmental data. We want to say thank you to our sponsors for their support: the Kentucky Department for Public Health, the Environmental Public Health Tracking Program, the Kentucky Environmental Education Council, the Kentucky Asthma Management Program, the Kentucky Population Health Institute, and the University of Kentucky's Center for Appalachian Research and Environmental Sciences. And finally, we would like to say thank you to our planning committee, whose valuable input and expertise has made this series possible. We hope you enjoy our webinar series.
Okay, Kara, if you want to make sure everybody's comfortable with Zoom, and then we will get started. Thanks.
Well, we appreciate everybody who has taken time out to attend today. And should you have any technical issues, I'll be working in the background. I'll just stay muted. Just message me in the chat section, and I'll do my best to try to resolve those for you. And most of you will have your microphones and your cameras turned off while the presenters are speaking today. But if you do have questions while the presentation is in progress, feel free to go ahead and enter them in, and we will moderate those and present those at the end. And right now we have just a quick poll of 3 questions. So I'll go ahead and launch that. If all of you guys would take a moment to fill that out, and we'll report the results at the end. And now I can turn it over to Sue Thomas-Cox.
Good morning. This is Sue Thomas-Cox. I'm with the Kentucky Department for Public Health and the Chronic Disease Branch, and Rahel Basse is with me, also with the Asthma Program. We are pleased to introduce Dr. Lisa DeBrondo as our speaker today. Dr. DeBrondo is with the University of Texas Medical School Department of Pediatrics. She is also an assistant professor of pediatrics at the University of Texas Medical School. She has hospital appointments at Children's Memorial Hermann and Lyndon B. Johnson General Hospital. She is also a member of the National Environmental Education Foundation's Pediatric Asthma Faculty Champions. And she is also medical director of the LBJ Asthma Clinic. So you can see she's a very energetic, busy, and she's also very an engaging speaker. And so we're just really privileged to have her with us today. So the National Environmental Education Foundation has developed comprehensive asthma care training programs regarding environmental management of pediatric asthma, which is accomplished through conferences, teleconference, webinars, workshops, ground rounds, and this presentation was developed in cooperation with me. So thank you, Dr. YBarrondo, for joining us today.
Thank you very much. Then, Cynthia, I'm waiting for you to share your screen with me. Let's see.
I sent the invite for you to be able to control. If you don't see that, we can go to plan B.
Okay. Yesterday, we had to play with it a little bit. Request remote control and request. Okay, is that working?
Yes, you're good now. Yes, all right.
Okay, and then I'm trying to figure out how to make this full screen.
Should be able to click the little at the lower right hand, the one that in PowerPoint. I think you should be able to click that. I can't do it now.
Yeah, it's, let's see if I can, no. Oh, I'm apologizing because I can't get down to the bottom of my screen. Oh, okay, somebody did that. Did I do that?
Actually, I think it flipped back to me, so you might have.
Oh, okay.
Sorry about that.
Okay, so it did flip back to you. Let's see. Now I'm requesting control. And let's see if it works. Okay. Did that work? No. It says I'm controlling your screen, but okay. Oh, I think there's a little lag. All right, so let's see. We'll go back. Cynthia, I don't know if I'm controlling this. It doesn't seem to. Oh, there's a little lag.
Yeah, there can be up to 5 to 10 second, unfortunately, lag in
Okay.
in between the click and the action. So
Yeah, you. Oh. Yeah. Yeah, so it says that you're controlling my screen now, so we should be good. And Kara, you may want to go ahead and take the poll down so that we can, that's not in the way for people who have smaller screens. And then I think we're good, yes?
Okay, there is definitely a lag because probably about several seconds. I'm so sorry, I'm jumping ahead because I've clicked too many. Oh, okay.
It's okay, and I apologize. I when I was muted, I said, we practiced this yesterday, everybody, but we appreciate your patience. We're all learning to do new things in this new.
Okay, I think that I have it now. The lag is pretty much gone. Okay, let's start up at the very top again. And thank you all for being very patient with me, someone who is IT challenged. So I do want to just mention that I've had the wonderful honor of being a member of NEAF's Asthma Faculty Champion Program since really 2007. We are a national network of pediatricians partnered with NEAF. We have provided education to over 13,000 pediatric providers and have trained them to deliver comprehensive asthma care through management of environmental triggers. I do not have any personal financial relationships with or commercial interests that are relevant to this educational activity. Oh, the lag is back again. Oh, I'm sorry, Cynthia, it is back. Okay, here we go. Oh, I did have to mention the disclaimer on the previous slide. The funding for this presentation was made possible by the Centers of Disease Control and Prevention, and the views expressed in materials or publications and by speakers, moderators do not necessarily reflect the official policies of the Department of Health and Human Resources, nor does the mention of trade names, commercial practices, organizations imply endorsement by the US government. Okay, so NEAF's guiding statements are what you see here on the screen. I do want to give you a little bit of background about NEAF. It was congressionally chartered in 1990 as a nonprofit complement to the Environmental Protection Agency. It is charged with advancing environmental literacy nationwide. It facilitates public-private partnerships in support of environmental education, and it is a nonpartisan, non-advocacy group. So our mission is to make the environment more accessible, relatable, relevant, and connected to the daily lives of all Americans. The Pediatric Asthma Initiative has the following goals: to integrate environmental management of asthma into pediatric healthcare, to improve access to quality asthma care, strengthen and advance competencies of healthcare professionals, and improve health outcomes for children with asthma. By accomplishing these goals, we help to contribute to the CDC's program goal of reducing the number of deaths, hospitalization, emergency department visits, school days, and work days missed, and limitations on activity due to pediatric asthma. Sorry, a little lag time on the slides here. All right, so our learning objectives for today, at the end of the presentation, attendees will be able to describe the top 6 guidelines implementation panel messages, restate the underlying expert panel 3 recommended clinical activities for the diagnosis and management of asthma, explain how to manage strategies of the CDC Exhale technical package to improve asthma management, demonstrate proper use of NEAF's environmental history form, describe multi-component best practice mitigation interventions for children with and identify indoor allergens, and a history of environmental triggers to eliminate exposures, create healthy indoor environments, discuss strategies on how healthcare providers, community members, and school officials can collaborate to manage asthma successfully, and identify common environmental triggers that impact the severity of asthma. And we'll go over all of those in depth. First of all, I'd like to talk about asthma disparities. You all are probably very well aware that asthma burden in America is unevenly distributed. So poor Black, Hispanic children living in households with incomes less than the federal poverty have a higher burden of asthma. They have twice the risk of developing asthma. African American and Latino children have worse asthma status comparable to white children. And compared to white children, they are 2 times as likely to be hospitalized, 3 times as likely to die from asthma. So there is some good news. I was looking at recent statistics for the prevalence of asthma, and really in about 2016 is the first time that we have had a decrease in the asthma prevalence in children. Back in 2009, it was close to 1 in 10 children, whereas now in 2018, 7.7% prevalence overall. But still, the disproportion of children of color is very noted. So 14.2% of Black children have a prevalence of asthma, and 13.6% of Puerto Ricans have a prevalence of asthma. And about 11% of that prevalence are children that live below the poverty threshold. So there also is variations in asthma care by race and ethnicity. So African American children are less likely to have made an office visit for asthma, and they are less likely to use inhaled corticosteroids. All right, this national survey on environmental management of asthma was done by the EPA, and it assessed the public's knowledge of environmental asthma triggers and their actions to manage these environmental triggers. So they surveyed about 3,400 individuals with a history of asthma, and they found that people from low income, low education households were more likely to have asthma. Less than 30% with asthma are taking actions to reduce their exposures to indoor environmental asthma triggers. People with a written asthma action plan are more likely to reduce these exposures. However, only 30% of people with an asthma action plan, of people with asthma, have a written asthma action plan. So that tells us that as primary care providers, we are not doing a very good job in getting an asthma action plan to every single patient with asthma. That should be our goal. Children with asthma are just as likely to be exposed to environmental tobacco smoke in their home as children in general. And exposure of environmental tobacco smoke is significantly higher in households with lower education and lower income. And parents account for the majority of these exposures. So you all are probably very well aware of the 2007 National Asthma Education and Prevention Program, Expert Panel 3 report, Guidelines for the Diagnosis and Management of Asthma. This 440-page document from the National Heart, Lung, Blood Institute published these Expert Panel 3 guidelines it was a consensus of the evidence-based recommendations for treatment of patients of all ages with asthma in both the primary care setting and also in the emergency department. However, because this report was so extensive, 440 pages, sorry, let me go back, a lot of primary care providers were not following the guidelines. So a year later, the Guidelines Implementation Panel put out a report called the GIP report, which identified barriers that prohibited PCPs from implementing the NAEPP clinical practice guidelines. And they developed recommendations and strategies to overcome these barriers. There were 6 priority messages, which we will talk about each one of these briefly. So message number 1, assess asthma severity. So as primary care providers, this is such an important step in treatment of pediatric asthma. We need to classify the patient's asthma based on measures of not only current impairment, but also future risk. So current impairment, think of the rule of 2s. You all have maybe heard of the rule of 2s. We commonly use that in our pediatric practice to help really determine if the child has intermittent versus persistent asthma. So intermittent asthma is going to be less than equal to 2 days per week of symptoms. And I always ask the parents, on average, think of this over the past month, how their child is doing with symptoms. So if they've had less than or equal to 2 days per week of their rescue inhaler, albuterol, bronchodilator, short acting. Persistent is going to be greater than 2 days a week of symptoms and bronchodilator use. Also ask about nocturnal awakenings over the past month. So anything greater than 2 nights per month would be consistent with persistent asthma. So persistent asthma also includes activity limitations. So any activity limitations is going to be consistent with persistent asthma. But in children, they may be well controlled during the spring, during the summertime, but then suddenly come fall and wintertime, there are a significant number of exacerbations. So this is what we talk about when we look at risk. So risk includes the number of exacerbations that require oral corticosteroids, whether it was in the clinic office or in the ED urgent care visits. So anything that is 2 or more per year would be consistent with persistent asthma. So just to keep in the back of mind that children's asthma is very dynamic. So every year you want to, and very frequently, depending on how often they have impairment at risk, you want to reevaluate these kids and make sure that you have good control. And so that goes on to the next slide, is assess and monitor asthma control. So there's various tools that you can use. You can see well-controlled versus not well-controlled and very poorly controlled, those kids who have almost daily symptoms, multiple doses of their rescue inhaler multiple times a day with extremely limited activity. So you want to look at comorbid conditions, as well as how are they using their medications. But we use a tool that is validated called the asthma control test. You all have probably heard of it. So there's also the childhood asthma control test that is for children 4 to 11. The ACT asthma control test is for 12 and up. So the older kids, they answer their own questions. The childhood ACT, the parents answer the last 3 questions, and the children actually answer the first 4 questions. And it gives us a very good idea of how well controlled they are regarding their activities, their nocturnal awakenings, their albuterol use, etc. Now for children less than 5, there is also the TRACK tool. This is the test for respiratory and asthma control in children, and we utilize this as well to help assess control. So message number 3 is using an inhaled corticosteroid. So once you have determined if this child has a specific severity, so say they have mild or moderate or severe persistent asthma, then inhaled corticosteroid is going to be the first line medication for control. It is the standard of care, as it is the most effective medication for persistent asthma of mild, moderate, or severe. It has a reduction in both impairment and risk, decreases daytime nocturnal awakenings. There are fewer hospitalization and urgent care visits with its use, and it increases pulmonary lung function. So the inhaled route, of course, is preferred over systemic route due to significant decrease in systemic side effects. There can be some systemic side effects with inhaled corticosteroids, but they are very well tolerated. And especially if you step down on your control to lower doses. There was also, back in the 1990s, when we really started to push for using inhaled corticosteroids, there was concern for a decrease in the linear growth. So many studies illustrated that there indeed was a decrease in linear growth with the use of inhaled corticosteroids, regardless of the dose. However, long-term studies show that this decrease in linear growth diminishes over time, and that when compared to non-steroidal inhalers like nodocromyl sodium or a placebo, that these kids actually went on to meet their predicted height. So it's very well tolerated, and it is superior to montelukast alone. So message number 4, use a written asthma action plan. So I'm going to show you an example of a written asthma action plan. There are literally hundreds of written asthma action plan. So you just have to find one that works for you. It includes medications, they are written in one place, all on the one side of the paper. It includes tailored instructions for the child during acute exacerbations. Tells them how much of their rescue medicine they need to use, how often, when do they need to call the office to get an appointment, when do they need to go directly to the emergency room. It is based either on symptoms or peak flow monitoring. Back in the 1990s, we tried to use peak flow monitoring with your green, yellow, and red zone based on the 80% predicted of peak flow, 50 to 80% for yellow, less than 50% for red. However, peak flow monitoring, there was a lot of poor compliance with its use. So now most of written asthma action plans, we base them on symptomatology. And I see pulmonologists, allergists also base theirs on symptomatology. So then this is an example of the asthma action plan. This is actually from the NAEPP guidelines, one such asthma action plan provided. And the nice thing about this asthma action plan is on the flip side, you can see environmental trigger control pointers. But there's all different kinds, but like I said, you just use the one that you find that is easiest for you to utilize. The one that I use comes from RUT Pulmonary, and it's very simple. It takes me less than a minute to fill out, but I do remind you, please go over it with your parents and the patients so that they absolutely understand it. All right, message number 5, schedule follow-up visits. So it's going to vary depending on the level of control. So you might have the patient come back every month until you achieve good control. Certainly, if you have a 3-month interval of very well controlled, then you can consider step-down therapy. It also depends on the time of year. If I know that the child has more asthma exacerbations, symptoms during this time of year, especially in the fall, winter season, then I'll be hesitant of stepping down until maybe the springtime. And also in the past 6 months, we've had significant challenges of scheduling these follow-up visits directly due to COVID. But the good news is in my clinic, we've actually been able to get a hold of many of our asthma patients because we have an asthma registry. So I encourage primary care physicians to establish an asthma registry for their clinic. And in the registry, we were able to determine what severity the child had, when was their last visit, were they well controlled, not well controlled. And so we were able to make almost 35 telehealth visits between March and June to follow up with our asthma patients. Now we're getting them back into the clinic as we are seeing more patients. And last but not least, message number 6, control environmental exposures. And we're going to concentrate on the remainder of this lecture, reviewing these environmental exposures and how to control them. So when you are assessing a patient, think of the common asthma triggers that affect your patient. And of course, it's going to depend on where you live in the United States. So for instance, where I live here in Houston, we are a tropical environment. We are near the Gulf Coast. We have high humidity virtually all year round. We have tropical storms like we just had this week. We have hurricanes, so we have huge problems with mold. And along with that high humidity, we have large problems with dust mite allergies. So that might not be true for where you're practicing. Think of poor air quality. Also in Houston, we have a lot of traffic and we have a high amount of outdoor air pollution. But also think of indoor air pollutants and aeroallergens, as they are closely linked to increased asthma prevalence and morbidity. And then keep in mind that environmental tobacco smoke is by far the most important indoor air pollutant. So always ask about environmental tobacco smoke. Oops, sorry, I jumped ahead. Let's see if I can go back. All right, so what is the importance of triggers in asthma? So allergen exposure plays a significant role in childhood asthma. Most school-age children with asthma have evidence of allergic sensitization. So up to 80% of these children with asthma can be directly affected by aeroallergens, whereas 20% of school-age children with persistent asthma are not necessarily atopic, but they are susceptible to pollutants, indoor, outdoor, and irritants, as are all children with asthma. And also remember, viruses are a major trigger of exacerbations. So this time of year, we are going to be getting into the flu season, of course, continuation with COVID. So schools also can be a source of exposure to allergens, and I'm going to show you some illustrations of that in just a minute. So the American Academy of Pediatrics published a 2016 clinical report. Matsui published the Indoor Environmental Control Practices and Asthma Management in the Journal of Pediatrics. And these are some key teaching points here. So individually tailored environmental control measures reduce asthma symptoms and exacerbations and are cost effective. Environmental history to identify those indoor exposures that trigger asthma symptoms should be identified. Indoor pollutants and allergens especially. Just because about 90% of our time is spent indoors, so those indoor exposures are going to be greatly impact the morbidity of childhood asthma. And then leading indoor allergens are pets, dust mites, mice, rats, cockroaches, molds, and pollutants include those airborne particulate matter, the secondhand smoke, also environmental tobacco smoke, same thing, and nitrogen dioxide. Assessment of clinically relevant indoor allergies is imperative, so serum allergic specific antibody test, IgE antibody test, or referral to an allergist for evaluation and allergy skin testing. And then environmental control strategies that are tailored to relevant indoor exposures include source removal, source control, and mitigation strategies are extremely helpful in the control of your pediatric asthma patients. So environmental control should target all of the exposures, and this is imperative to achieve maximum benefit. So in this publication, there is a great sample environmental control plan. It's in the supplementary data, and it has goals and actions for children, all children with all severity of asthma. It is a checklist, and it's easy to follow, and these strategies are tailored to the relevant indoor exposures. So this is a great tool for primary care providers or any healthcare providers that are going out to the home to do a home assessment. All right, so the Environmental Management of Pediatric Asthma Guidelines for Healthcare Providers is another great tool. This was published by NEAF. It was founded upon your National Heart, Lung, Blood Institute, NAEPP guidelines, developed for primary care providers, myself, authored by the Expert Steering Committee, peer-reviewed, built on scientific literature and best current practices. So I'm going to go over the environmental history form very quickly. It has environmental intervention guidelines and sample patient flyers. And this is available online, both in English and Spanish. It's available in hard copy CD-ROM, but most people have it readily available via the web links below. Oh, somehow it skipped very quickly. Sorry about that. Okay, this is the environmental history form for pediatric asthma. It is very simple to read, very simple to fill out. It's available both in English and Spanish, a quick intake form administered by a healthcare provider, available online, PDF and Word document, and can be pasted, recopied, or scanned into your EMR. The questions, like I said, very easy, simple, elementary school education, 4th grade can read it in a yes and no format. So a lot of parents will think of their own home environment as they are answering this, but I encourage parents to think of what are the other areas that could be major triggers. So if they are staying at grandma's house for any length of time, they might think of the exposures through daycare, car, or work. And like I said, it's designed to capture major trigger areas. So example questions are, do you have a furry pet? Are there smokers in the home? If you have an adolescent, does your adolescent smoke? Do you see do you see or smell mold or mildew? Do you see mice, rats, cockroaches in your home? So like I said, it's designed to identify some major triggers. And then once you find those major triggers, you want to follow up on any yes answers with more in-depth questions on the intervention guidelines fact sheets. And this explores the more in-depth exposure sources and what are the parents' current practices to mitigate these exposures. It also gives intervention recommendations and sample patient handouts to download and give out to your families. Additional resources are also on the initiative's website. So real quickly, who do we recommend to get an allergy evaluation or referral? So the NAEPP guidelines, they stress that it is imperative to have an assessment of sensitivity to indoor air allergens if there is persistent asthma, and this is for any age group, children and adults. So how do we do this? Serum allergen-specific immunoglobulins antibody tests may be performed, or referral to a board-certified allergist for allergy skin testing, which is still considered the gold standard. So low-cost environmental interventions are reasonable, especially where widespread exposure occur, such as house dust mites in my neck of the wood, mold exposure, for example. However, costly interventions, please consider those only after you have confirmation of those allergens, or if you are considering getting rid of the pet, finding another home for the pet. You want to confirm that allergen. So if you are doing the allergen-specific immunoglobulin antibody test, then make sure that you are testing only to selected relevant allergens. Okay, sorry, my slides are stuck. Okay, so let's look at the evidence for environmental trigger control. All of these environmental exposures obviously can contribute to asthma severity and morbidity. So let's talk about cat allergen and pet allergen first. So about 25 to 65% of children with persistent asthma are sensitized to either cat or dog allergens. These allergens are, pet allergens can be distributed to many, many other locations. So they are small, they're airborne, and they adhere to clothing and many other surfaces. So these allergens, they are protein that come from the saliva and also dander from the glands in the hair follicle. So cats especially, their allergen is very tenacious. It sticks to all kinds of surfaces, and kids bring those allergens to class. So there is a direct association between the proportion of cat owners and the level of cat antigen that has been found in classrooms and schools, illustrated by these two studies by Almquist. So cat allergen that's carried into the schools on the clothes of cat owners can directly affect, sorry, let me go back. Sorry, I'm having some issues. My computer, I apologize, it's slow to respond. I hope I'm not frozen. it's not responding to my.
So, Dr. YBarrondo, this is Cynthia. It looks like you've lost your control. So if you just want to
Oh, okay.
just tell me to forward, I can do that for you.
Oh, can you back up just for a minute? We skipped. So sorry, guys. Okay, and one more slide back up. Okay, so getting back to this study, cat allergens were found in dust, carpets, upholstery, and desks that were at school. And of course, if cat owners bring these high level of cat allergens into the classroom, then that exposure to cat allergen at school can indeed exacerbate asthma in those children sensitized to cat, even if they don't own the cats. So the same thing can happen with dog allergens, and keep in mind that allergens to other pets can occur. So other furry pets like rabbits, ferrets, gerbils, hamsters, etc. Okay, next slide. Okay, so let's look at a study to try to control the cat allergen in the home. This randomized controlled trial with 35 cat allergic children with asthma and owner of cats. The intervention used the HEPA air cleaners, impermeable, allergen impermeable mattress and pillow covers, and then cat exclusion from the bedroom. So although there was a reduction in airborne cat allergen levels, both in the bedroom and in the kitchen area, it did not have any effect on disease activity. However, a second study by Wood showed that in cat allergic individuals with asthma, intranasal steroids were very effective in not only reducing the allergic rhinitis symptoms, but also disease activity of the asthma. So that might be an option in some of your families who are not willing to give up the home ownership of their pet. Next slide. So animal allergens, advisement and tips for families for their home. You may find a new home for the indoor pet, but I would suggest not mentioning this until you have confirmation of that allergy. A lot of parents are very reticent to give up that beloved pet. However, if they are truly allergic to those pets, if keeping the pets, try to keep them outside if possible, and at most keep them out of the child's bedroom. HEPA air cleaners are questionable in their help. HEPA vacuum cleaners maybe benefit, but there's not substantial evidence to show that. Frequent cleaning and the use of impermeable allergen encasements for bedding is recommended for cat allergens because even when you get rid of that cat, then the allergen can persist in mattresses for years after the cat is removed from home. And just keep in mind that after you get rid of that cat, then that cat allergen can still hang around for a good 6 to 8 months. Next slide. All right, let's talk about mouse allergen. So mouse allergen is small airborne proteins. About 18 to 51% of children living in an urban low-income household with asthma are sensitized to mouse allergen. So mouse allergen exposure is linked to an increased risk of uncontrolled and more severe asthma among sensitized children. It is very prevalent. 75 to 80% of US homes have detectable mouse allergen. The inner city, however, the home concentrations are up to 1,000-fold higher than suburban homes. And this study out of Johns Hopkins looked at children living in inner city Baltimore. Children with asthma, 41% were sensitized and exposed to mouse, and it was associated with acute care visits, decreased pulmonary function, and associated with poor asthma health overall. Next slide. So mouse allergen can also be a significant source from school exposure. These two studies looked at classrooms in the northeastern schools and matched with home samplings of the first study's smaller 23 asthmatic children. The second study was a much larger study, 284 children with asthma, and found that mouse allergen was significantly higher in these classrooms in the northeastern schools compared to their home. So just keep that in the back of your mind. Exposures associated with asthma symptoms through school showed increase in asthma symptoms and also decrease in pulmonary function. Next slide. So for studies that support control of mouse allergen is illustrated with this one. This is integrated pest management, IPM, that is used to control mouse allergen. A small study of 18 homes of children with persistent asthma and positive mouse allergen, randomized controlled test to those kids randomized to receive intervention of integrated pest management, where holes were filled, vacuuming and cleaning was encouraged, and then use of low toxicity pesticides and bait traps were also used to help control mouse allergen. And they found that mouse allergen levels were significantly reduced during the 5-month study period, 79% in the kitchen, 77% in the bedroom, whereas those children in the control group had a over 300% increase in the mouse allergen in their areas. I'm going to talk a little bit more about IPM in the next couple of slides, but next slide, on going to cockroach allergens. So cockroach antigen can also, you can also have a significant exposure through school. So cockroach allergen and exposure to high levels helps explain the frequency of asthma-related problems, especially in the inner city. And over 70% of dust samples from schools and child care settings may contain cockroach allergen. And these highest levels were found in rooms containing food. So allergen is widely spread throughout environments, but the highest concentration is really near those food sources and water sources. So for example, behind appliances, especially in the kitchen, and in cracks within the kitchen area. And then allergen can persist for months, even after successful extermination of cockroaches. Next slide. So let's talk about integrated pest management to control the rodent population, mouse, rat, and cockroach problem. So integrated pest management, or IPM, significantly reduces exposure to your pest antigens. It involves the least toxic methods first. The strategies vary, but include filling holes both inside and outside the home, sealing cracks, fixing water leaks, because these pests, they follow the water source and they have to live with water. Vacuuming and cleaning, wiping down counters, especially in the kitchen areas. Low toxicity pesticides and bait traps are very effective and don't pose a significant toxicity to young kids and pets. Plastic food storage containers with seals, and then also garbage and trash cans with seals, and then general education. It can be very labor intensive, but very effective in controlling pest allergen. Next slide. So this study shows that integrated pest management was very effective in controlling the New York City Public Housing Department's cockroach problem. So just to give you a background, the New York City Public Housing Department is the largest one in the United States. It is where there is the highest prevalence of children in New York City with asthma live, and also it has the highest prevalence of childhood hospitalizations, urgent care, and ED visits. and it may be a large part may be attributed to the cockroach problem that is observed. So this study was a randomized controlled trial. There were 280 apartments in 13 buildings that were randomized to receive either IPM versus the control group. The IPM group, there was a single visit by a pest control professional. They trained public housing residents to become the IPM technician for their building. IPM, as previously described, was utilized, and then solid or gel baits were given to the families and households as needed. So control group received the standard NYCPH pest control on a scheduled basis, which included baseboard spraying with pyrethroid insecticide, which, by the way, if someone without asthma were to inhale, it could cause a severe bronchospasm. So someone with asthma, if they were to inhale pyrethroid insecticide, could have a severe exacerbation. Also, any topical contact with the skin can cause a severe dermatitis. So it can be potentially toxic. The IPM group had a significant lower cockroach counts noted by 3 months and sustained through 6 months. And just to give you an idea how bad the cockroach problem was in the New York City Public Housing Department, about a third of apartment owners, they had over 100 cockroaches that they trapped per week in these traps. The IPM group had lower cockroach allergen levels, and this also was sustained through the following 6 months and the past year, and through a year. And because it was not only very effective, it was also much lower toxicity. Now the New York City Public Housing Department is using IPM as an effective and safer means than the standard application of pesticides for controlling their cockroach problem. Next slide. All right, so Portney published the Environmental Assessment and Exposure Reduction of Cockroaches, a practice parameter, in the Journal of Allergy and Clinical Immunology back in 2013. And the practice parameters of cockroach allergen control are summarized with a few of these statements. So exposure to cockroach allergen in schools and homes should be minimized to reduce the risk of cockroach sensitization. Cockroach exposure should be minimized to reduce the risk of asthma morbidity in those sensitized subjects. Reservoirs of cockroach contamination should be cleaned, removed to prevent additional exposure. IPM, with a combination of interventions, appears to be the most effective method for preventing and eliminating the infestation, and it should be used to decrease cockroach exposure to reduce asthma morbidity. Next slide. All right, on to mold control. So where I live, like I said, it is a huge problem, and I saw it directly impact my patients with asthma after 2017 Hurricane Harvey, which had significant damage widespread in the Houston and vicinity area. And many of my patients had problem with water intrusion into their household with subsequent mold problems. So mold control is directly affected by high indoor humidity and water damage, which precipitates the mold growth. Mold is ubiquitous in the environment. It's both inside and outside. It's more common in the poverty areas where decaying and old homes, schools, and buildings are prone to water damage. Mold is associated with significant respiratory symptoms, including asthma, and there is sufficient evidence to support an association between mold exposure and symptoms and exacerbations in our asthma patients. Next slide. Oh, and about 50% of our children with asthma are actually sensitized to mold. Okay, so let's look at the study looking at mold control. It was a randomized control test in children with persistent asthma, 2 to 17 years of age. And before randomization, all children received info on improving indoor air quality, home fungal sampling, spirometry, and put on appropriate medications depending on the severity of their asthma. So that led to a decrease in the number of asthma symptom days in all of the children enrolled in this study. So the remediation group, they received significant household repairs. They had reduction of water, infiltrations, removal of any damaged drywall, for example, HVAC system repair. And it actually cost a significant amount of money, about $3,500 on average per household. But the results were very significant. So it showed decrease in mold levels persisting through 12 months. This correlated with a decrease in asthma symptom days. This translated to half the number of acute care visits during the year of study compared to those in the non-remediation group. So there were no further changes of symptom days in the control group. So this illustrates the significant improvement of mold control on the impact of pediatric asthma. Next slide. So what can we recommend to our pediatric patients? So mold and mildew prevention and cleaning up the mess. So we want to control the moisture and decrease humidity to less than 50%. So unfortunately, some of my pediatric patients, even though we live in such a hot environment, they do not have central air conditioners. So indoors, they have a very high humidity, as well as outside. So we can recommend dehumidifiers. Also recommend not to use a humidifier, although we commonly recommend to use humidifiers at nighttime for our pediatric patients to help them breathe easier when they have a cold, but not recommended for children with asthma. Increase the ventilation, check the faucets and pipes for leaks and repair, identify and stop those sources of water intrusion. So clean up of small areas that are less than 3 by 3 feet can be done with detergent or a dilute chlorine solution, 1 to 10 mixture with water is acceptable. However, it is much better if it's on hard surfaces. So if you have porous surfaces, then you're probably going to have to get the experts involved, especially if you have larger surfaces. Chlorine bleach it gives a very good cosmetic effect. However, just keep in the back of the mind that it may not really eradicate all of the allergens. And please note that you don't want to mix any chlorine with cleaners containing ammonia, as this can cause a toxic vapor and be poisonous for all. Next slide. Okay, let's talk about these critters, dust mites. So dust mites, the allergens come from larger particles. They don't remain in the air for very long because they are large, and they come from the proteins from both the feces and also decaying body parts of the dust mite. 30 to 62% of children with persistent asthma are sensitized to dust mites. And like I said, in my neck of the woods, we have a huge problem with dust mites, high levels year round. So this Cochrane meta-analysis of dust mite interventions really came to the conclusion that there was no effect on asthma improvement. However, these included studies with little or no effect on dust mite exposure, and patients may not have even been tested for dust mite allergies. So we know that in our pediatric studies looking at dust mites sensitization, that children with asthma sensitized to dust mites have found that these dust mite interventions can have a beneficial clinic effect. And next slide is an illustration of that. So this randomized controlled trial is one of over a dozen randomized controlled trials that report a decrease in allergens with these allergen impermeable mattress covers. So this study had 60 children, all with asthma, sensitized to dust mite allergens. And they used the allergen impermeable mattress covers, pillow, and box spring covers, and found that they had a significant reduction in dust mite allergens for the intervention group. And this was translated to a significant decrease in effective dose of inhaled corticosteroid by 9 months, and by 12 months, it was half the dose compared to the control group. However, there was no effect on bronchial hyperresponsiveness, which is a measure of asthma control that most pulmonologists and asthma specialists utilize to determine control. So this leads us to the question, is comprehensive trigger control a better idea? And the answer is most likely yes, because children not only are high risk for dust mite allergens, but they can have other aeroallergens and other triggers as well that are non-allergenic. Next slide. Oh, and just real quickly about the allergen impermeable mattress covers, just wanted to point out that it has, in order to be designated an allergen impermeable mattress cover, it has to have a pore size of less than 10 microns. To put that size into perspective, a dust mite on average is about 250 to 320 micrometers or microns. Their eggs are 15 to 20, and their feces are about 20 microns. So the allergen impermeable mattress covers prevents that direct exposure to those dust mite allergens. All right, so Portnoy published the Environmental Assessment and Exposure Control of Dust Mites, a practice parameter in the Annals of Allergy, Asthma, and Immunology. It was a review of the evidence by the Joint Task Force from the American Academy of Allergy, Asthma, and Immunology, American College of Allergy, Asthma, Immunology, and Joint Council of Allergy, Asthma, and Immunology. So here's a partial summary of the recommendations. We want to minimize the exposure to dust mite allergens in those susceptible children, minimize exposure of dust mite sensitized children to dust mite allergens, to decrease their asthma morbidity and possibly rhinitis, and also test those patients for dust mite IgE through skin testing or in vitro. We want to keep the relative humidity in homes between 35 to 50%, wash bedding weekly, and it does not have to be in scalding water, which is a good safety precaution for our children. Next slide. So continuation of recommendations, dust mite allergen proof casings, those are the impermeable mattress covers that I talked about, are important, and they are a good bang for your buck. They can be very inexpensive. I've seen some online through Amazon that you can buy for your twin mattress, a regular standard pillow for less than $4 for the pillowcase, and for the mattress, less than $12. You can also buy more high-end ones that are made out of silk, so that those can run you a couple $100 if you have a king-size mattress. But HEPA filtration alone has an uncertain benefit, given that these are large protein particles that fall out very quickly. But regular vacuuming, especially with high efficiency particulate air filtration, HEPA filters may be a benefit. But keep in mind that HEPA filtration and those HEPA vacuum cleaners can be very expensive. So a lot of my patients cannot afford these type of vacuum cleaners or filtration. So that's why I really concentrate on the impermeable mattress covers. But multifaceted approach for dust mite avoidance with repetitive and sequential interventions is recommended, and offer immunotherapy to dust mite allergic patients with allergic rhinitis and mild moderate asthma. Next slide. Okay, so dust mite, simple and multifaceted but effective interventions in the home can be as followed. So remove or wash those stuffed toys weekly. Now, if you have a lot of stuffed toys, I'd recommend the child just choosing a few to keep. And if they can't be washed on a regular basis, then you can actually stick them into the freezer for a couple of days, and that can kill the dust mites. You want to encase all the pillows, mattresses with the allergen impermeable encasings like we talked about. Washing bedding weekly to remove the allergens. Scalding, like I said, is not necessary. Those temperatures that are even cold are very effective in reducing about 90% of the allergen. So again, like I said, the HEPA air filters are plus or minus. More effective would probably be the vacuum with the HEPA filtration. But again, consideration of what your parents and patients can afford. Next slide. All right, let's talk about indoor air pollution. So you can have a house that is in one of the highest poor air quality of town, and yet the indoor air pollution can be much higher inside, and that can be directly due to cigarette smoke. So I'll talk about that in just a minute, but indoor air pollution typically comes from the majority of two sources: the nitrogen dioxide, which is a byproduct of combustion, and particulate matter exposure, which includes cigarette smoke. So nitrogen dioxide comes from both outdoor exposures as well as indoor exposures. So it affects both allergic and non-allergic children with asthma. And indoor sources include gas heating, appliances, older wood-burning stoves, unvented space heaters. You all probably see more of that where you live compared to where I live, where it's hot virtually all year round. However, we do have a lot of kids that do have gas heating appliances. High indoor nitrogen dioxide concentrations are linked to worse asthma status in children. Also very important is the particulate matter exposure, and that directly correlates with indoor environmental tobacco smoke. So it's associated with lung inflammation, decreased lung function, and respiratory symptoms in children with asthma. Indoor particulate matter, also think of partly from outdoor particulate matter, but it can come not only from smoking, but wood-burning stoves, fireplaces, electronic nicotine delivery systems, e-cigarettes and vapes, that is, cigarette smoke, incense, marijuana, candles, etc. But just keep in mind that cigarette smoke is the major contributor to indoor particulate matter. Up to 60% of children in low-income households are directly exposed to secondhand smoke. Next slide. So elimination of that environmental tobacco smoke is going to be the key. It is the first line of intervention for children with asthma. We want to establish and maintain smoke-free environments. Not only think of home, but think of where does a child spend a lot of time. It could be in grandma's house, it could be in the car, there could be an individual owned childcare where the owner smokes. So encourage smoking cessation for your families. Portable HEPA air cleaners have been shown to be effective in reducing the indoor particulate matter concentrations by 25 to 55%, but it is less effective than smoking cessation or home ban of smoking. However, if the parents insist on continuing to smoke, then really they need to buy a HEPA air cleaner. It does reduce asthma symptoms and exacerbations. However, it does not reduce the air nicotine and exposure to other toxic gaseous components in the tobacco smoke. So we have to make sure our parents are aware of that as well. Next slide. So indoor air pollution and possible interventions include installing exhaust fans close to source of contaminants. So over the stove if there's a lot of cooking going on, ventilate the room if there's fuel burning appliances, and avoid the use of products that emit irritants like perfumes, candles, incense, air fresheners that can exacerbate asthma in children, and avoid those air cleaners that generate ozone. Replacement of gas stoves with electric stoves is really one of the few methods of decreasing the nitrogen dioxide. Okay, next slide. Okay, I do want to spend a little bit of time about vaping because we are in the midst of an epidemic for our youth. So the really vape pens, e-cigarettes, that hit the market back in 2007, but it really didn't become an epidemic until Juul was introduced in 2015. And really, it is directly responsible for the vaping epidemic that we see in children. The vaping epidemic over the past several years it has really increased because that Juul is a small receptacle. It resembles a flash drive. It was very enticing to a lot of our kids because it had all these variety of flavors of the vape juice. And in 2019, a study showed that the majority of the students and young adults that were interviewed did not know that Juul pods all contain nicotine or THC from marijuana. And then you all probably have heard of EVALI, that's the e-cigarette and vaping that's associated lung injury directly due to vaping products, mainly associated with the THC, but it has been associated with other components as well. And back in 2019, we had multiple kids in our ICU that were on ECMO. One child was on ECMO for 2 months. And directly due to EVALI. And in 2019, by November, there were 39 deaths from EVALI. So this really led to the ban on Juul selling most vape flavors and also not being available to the children that are under 18. So the top study in 2017 looked at students with asthma, and they were actually found to be more likely to use e-cigarettes than those without asthma. And that was actually true for all tobacco products, which is astounding to me. And in 2020, we are actually seeing a downswing in the percentage of high school and middle school students reporting the current e-cigarette use compared to last year. And this may be in part because of the ban from Juul for young kids and also the unable to buy the vape flavors. It may also be directly related to COVID, and the kids are socially isolating as well. And just keep in mind that aerosols contain irritants and toxicants that are implicated in the pathogenesis and worsening of lung disease, including asthma exacerbations. So propylene glycol, for example, benzoic acid, vegetable glycerin, different flavorings that are synthetic substances, particulate matter, metals, heavy metals, and carcinogens. Next slide. Okay, so we talked about previous studies using, focusing really on single allergen intervention rather than multiple exposures. But this intercity asthma study was a great example of using combined asthma trigger management. And it evaluated the effectiveness of home-based multi-trigger environmental intervention for those children with moderate to severe persistent asthma, school age, to determine if there was an improvement of asthma symptoms and decreased use of healthcare services. So you can see the demographics of the children involved in the study came from low socioeconomic status and a lot of minorities. There was 1 year of intervention, 1 additional year of follow-up, and the evaluation included questionnaires and then skin testing, home health sampling for various allergens. And those interventions were aimed at patient-specific triggers. So allergen, impermeable mattress and pillow covers, depending on cat and dog, dust mite exposures, HEPA air filters, vacuum cleaners, especially for those households where parents smoked, and professional pest control to implement IPM. Next slide. So the results were significant. So there were significantly fewer days with symptoms, decreased albuterol use, decreased unscheduled office visits, decreased ED and urgent care visits. And this correlated with a greater decline in the level of allergens at home. This persisted through the second year of follow-up, so it was sustainable. And dust and cockroach allergen correlated with fewer complications of asthma if they were decreased. The second study looked at a cost-effective analysis of these results, and on average, about $1,500 was spent per family, and this related to 38 more symptom-free days, which is right at about $28 per symptom-free days. And if you think about one hospitalization or even urgent care visit, which could run, ER visit, which can run into the thousands of dollars, this is a great bang for the buck. So it was a substantial savings overall. Also, it directly impacts the savings to our family. Most of the patients that I see, our families are not, they are not salaried employees. They work and earn income depending on the hours that they put in. So if they're home taking care of their sick child, then that is lost wages for the family. All right, next slide. So this community guide systematic review of 20 studies targeting children looked at the effectiveness of multi-component interventions. So it evaluated the evidence on effectiveness of home-based, multi-trigger, multi-component, environmentally focused interventions, and the findings were substantial. So in reduced asthma symptom days, reduced school days missed, reduced number of asthma acute care visits. So the conclusions were that interventions with an environmental focus are effective in improving overall quality of life and productivity in children and adolescents with asthma. Next slide. All right, so this following study showed a significant reduction in asthma exacerbations for children, which correlates directly with reduced traffic during the 1996 Atlantic Olympics. Multiple studies have demonstrated significant association between increased ozone levels and increased asthma exacerbations of children and school-age children, especially those living in high poverty zip codes. So this study looked at around-the-clock public transportation, decreasing individual and private cars to the downtown area because of the Atlanta Olympics. More flexible telecommuting work schedules were encouraged, and the results were significant decrease in morning traffic counts, and that directly correlated with a daily peak ozone concentrations that were also decreased, and that's illustrated in the following slide. So you can see ozone levels before, pre-Olympics, during Olympic period, and post-Olympic period, especially with ozone exposure. Next slide. So how did this impact children's asthma exacerbations and hospitalizations? So those kids who presented to the emergency room was significantly decreased by looking at the asthma claims from Medicaid and both private insurance by over 40%. Next slide. Now, the Southern California Children's Health Study looked at traffic-related pollution and the direct correlation with the development of asthma and wheeze in those children living close by to high traffic roads. So it was a cohort study examining the effects of local traffic-related pollutants near children's schools and their homes. And it found that asthma and wheeze were strongly associated with residential proximity to a major road. And that was greatest with those children living within 300 meters of major roads or freeways. And that risk increased significantly of those living within 75 meters. The greatest effect was in girls. And the strongest association of development of asthma was in children with a parental history of asthma. The incident of asthma was positively associated with traffic pollution among children at school and home with a hazard ratio of 1.6. So because of this study, California then passed a law prohibiting schools being built within 300 meters of major roads. And I'm not sure if Kentucky has the same rules, but I know here in Houston and all of Texas, there are no such regulations to prohibit those schools being built near major roads. In Houston, I can go down any major highway or large road, and right next to it in the feeder road, I see high schools, middle schools, and elementary schools. Next slide. All right, last but not least, air pollution. So air quality, like I mentioned before, can directly impact the severity of asthma symptoms and asthma exacerbations. So possible outdoor air interventions include monitoring those air quality index levels. So we have to make our parents aware of how to do that. So it can be simple to look at ozone, particulate matter, and other substances, pollutants in the air, just through certain apps. So I actually pulled up an app last night, and it's called the Air Lookout. And so I was playing around with it. Here where I live in Houston, I'm in the green. We have good air quality. Our air quality index is about 15 today. But I was looking up Louisville, Kentucky, and it looks like the air quality index is moderate at 52. So those of you who live in Louisville, you know, it can be a little bit more worrisome. It is safe for exercise, but just realize that if it gets into the orange zone, then it can be unhealthy for sensitized groups, especially our kids with asthma. And then also we want for patients to be aware that they need to contact us, their healthcare provider, if their albuterol use is needed more frequently the day after the AQI index is high. And of course, if you look at the map with this app, if you look at what's happening on the West Coast where all the wildfires are, there are actually AQI indexes that are in the red and purple range right now. So very unhealthy for all walks of life. Next slide. All right, so in summary, our best practices for asthma include a written asthma action plan, use an inhaled corticosteroid per the National Heart, Lung, Blood Institute guidelines for persistent asthma, reassess impairment and risk, preferably during periodic asthma checkups. Environmental management can and should supplement good medical care. Ask about those environmental exposures and seek ways to intervene. So low-cost interventions, they are cost-effective in our children. And consider an allergy referral to define those exposure risks. All right, next slide. Almost done. So I do want to talk to you about the CDC, the National Asthma Control Program, just real quick. The CDC NACP program funds 24 states, including Texas and Kentucky, to improve the reach, quality, effectiveness, and sustainability of asthma control services and to reduce asthma morbidity, mortality, and disparities by implementing evidence-based strategies through a 5-year cooperative agreement. So it's based on the exhale idea. So E, education on asthma and self-management, and it gives various approaches how to achieve that. X, extinguishing smoke and exposure to secondhand smoke. The program provides tobacco cessation counseling in group and individual sessions. H, for home visits, although those have been put on hold right now due to COVID. But hopefully we will eventually be able to pick up again regarding conduction of environmental history and trigger assessments within the home and provide that education and resources on elimination. A, achievement of guidelines-based medical management, L, linkages and coordination of care. and that promotes coordination of care among healthcare providers, health plans, case managements, schools, communities, and patients. And environmental policies or best practices to reduce the indoor and outdoor asthma triggers. So establish a resource list of home improvements, incentive programs, and adopt smoke-free policies. So next slide. And so for your, in Kentucky, your CDC National Asthma Control Program resource contact is listed right here. So please take advantage of it. And then next slide. So our entire lecture training program has actually been developed into an e-learning module. And so this is currently available. So y'all please review that, and you can earn some CME credit also for participating in this. And here's the information regarding this. And you can find out further information about it through NEAF. So this presentation with supplemental materials are the property of NEAF. All other rights are reserved. And now we can go on to questions. I think that is the last slide.
We'd like to thank Dr. YBarrondo for her time spent with us today, and to NEAF also for this very comprehensive coverage of everything almost that we need to know a little bit about asthma in terms of assessment of the patient, assessment of the home, the asthma control test, all the way through those comprehensive environmental trigger interventions, and coverage of exhale. So we have time for maybe a couple of questions because we're almost at time. One question, which was not anything that you covered, but a concern about possibly vaccines and vaccinations that might be responsible for allergies and allergy-related symptoms.
So are you talking about our routine vaccinations that we use in children?
Yes, there was a study cited out of UCLA that looked specifically at DTP vaccine to see if it might be responsible for allergies and allergy-related symptoms such as asthma.
Now, I have not heard of any correlation of increased allergens related to vaccines. So I'm sorry, but I'm not aware of that study. But I have not heard anything from my resources regarding that any vaccines increase the allergens in children. I mean, what it may be referring to is the hygiene hypothesis, but that is related to a child's exposure to various endotoxins within the environment. So it has been shown that those children living on farms where there are livestock animals, they have a higher exposure to these endotoxins and in the environment, and they have a significant reduction in allergies and asthma. So that may be what that study could be alluding to, is the hygiene hypothesis.
Thank you. We had another question, or sort of a concern, I guess, about frequent cleaning with disinfectant cleaners can also be a concern. How do you go about kind of explaining that to patients and their families?
So frequent cleaning, of course, is very important, especially when you're trying to decrease the pests, the mice and the cockroach allergens. However, those cleaning fumes can affect the kids with asthma. So the best thing is to have well-ventilated rooms when you're using cleaning products. Certainly do not mix any ammonia with any chlorine bleach. Like I mentioned, has a very toxic vapor that is toxic to everybody, not just kids with asthma. Getting the kid out of the room while you're cleaning would be more appropriate. And it might be a good excuse for the kid not to have to participate in cleaning, but they can always use just soap and water.
Very good. And then a lot of people talk about green cleaning.
Yes. Yeah, vinegar may be a good option, and that's been, I mean, I use vinegar to clean a lot at home. So, you know, there are good options other than high ammonia detergents, which can create those toxic fumes.
Very good.
And then And then I did want to also just make a comment about COVID and relationship to asthma exacerbations. So hot off the press, I have a publication. It's called The Impact of COVID-19 on Pediatric Asthma, Practice Adjustments and Disease Burden. So this was a really interesting study. It looked at respondents basically worldwide, throughout the, not just the United States, but throughout the world, of providers that took care of kids with asthma. And they did not find really a significant impact of COVID on pediatric asthma services. So it was a lot better than expected in actually disease control. And then control was negatively affected in only about 10% of the children, where the positive control was reported in 20% of children. And then adherence also appeared to increase. A lot of that was attributed to a lot of the telemedicine that providers were able to do, and possibly reduced exposures. The kids were quarantined, they weren't outside, they weren't socially congregating, so decreased viral infections. So that was really interesting. You would have thought that there would be a significant decline in asthma control with the whole COVID situation.
Thank you. Thank you. I'm glad you brought that up. It's one of those things, I think that's a little confusing, but when you really look at what you've just explained, and people are not maybe getting the viruses being exposed and those kinds of. And as we talked about yesterday, when the kids go back to school,
yes,
third week of September being peak week, we may see
exactly that. Yes, I wanted to mention that we are getting into the third week. Our peak week of asthma attacks are coming up, so we need to be vigilant, especially with the schools opening up again and the flu season in front of us.
Well, we are a little past 1:30, and we appreciate it so much. Again, it was wonderful. Everybody I know will be looking up all those resources from NEEF. I see that Cynthia has put in chat how to make sure that you get CDs, and if you want to go over that, Cynthia, I'll stop. But again, thank you so much, Dr. YBarrondo. That was wonderful.
You're welcome. You're welcome. Thank you so much for having me. I really appreciate it.
Yeah, thank you so much, everybody. There's a message in there with links to the survey for everyone except those that are receiving the health educator CEUs. There's a separate evaluation link for those of you who are CHES. And you'll also get an email from me in the next hour reminding you, but you've got to do it in the next 48 hours. This is new. And it only takes 2 or 3 minutes. We really appreciate your feedback. So thank you everyone today, and especially thank to you, Dr. YBarrondo. Appreciate it.
Thank you so much, Cynthia. Appreciate it. And thank you, team.
Thank you. Bye-bye.